Hi, dear participants and panelists. Thank you so much for joining us in this webinar that has been organized by International Association of Public Health Logisticians with Tanzania Chapter. My name is Richard Silumbe, the president of the chapter. And together with this call, I have my colleagues Farhan, who is the vice president, and Harrison Maliki as a secretary. And we're really excited to see you participating with this call, which we believe this is a very interesting one of the webinars that the chapter will continue to provide. So as you can see, we are on time and we need to kick off. I can see the number is keeping increasing, but we should stick on time, I think so. So as I said, we have a talking point today, which will focus on an overview of Tanzania Immunization Supply Chain. And this will be presented by Paschal Bwire and also Johnson Kisanga. So a bit of the structure of this call that we'll have a presentation. And at the end of the presentation, and if you have any question or comment during the presentation, we are asking you participants to put your question on the tab below, which is Q&A, which is question and answers. Chat, you can put your question or comment while the presentation is going on. But also, if you are not comfortable using Q&A section, even during your chat, you can put your question or comment as well. So Farhan will be able to manage and read those questions and comments that you will be providing. I think that will be much more valuable for both of us. So again, another logistics we can say we do expect it to have IVD program manager, Mr. Bulula Ngwegwe. He'll be providing, as a special guest of this call, will be providing a kind of a note. He will be already joining our call. So we are so happy and very excited to see the collaboration that we have with the government. Yeah, so feel free whenever the presentation is going on, put your question or comment in the Q&A chat or during the chat. And just to make us much more familiar with you, please, you can continue to write on the chat the name, the where are you coming from, as usual during the meetings. That would be helpful. So without wasting much more time, I can see the number is keeping on increasing. Let me introduce the presenter for today's topic. So we have Paschal Bwire. He is a registered pharmacist with a bachelor's degree of pharmacy and master's of science in pharmaceutical management. Paschal is a vaccine program manager at Clinton Health Access Initiative CHI and has over 8 years experience of working in immunization program and hospital services. He is performance oriented and driven and creative with a good program pitching and organization skills. Prior to working with CHI, Paschal worked with John Snow or GSI, Management Science for Health, and also at Muhimbili National Hospitals. And he has also participated in partners consultation workshops for effective vaccine management assessment, version 2, web-based tool for development that was developed in 2016. And he is also a co-author of a descriptive case study titled as Averting Maternal Death and Disability in an Urban Network of Care in Dar es Salaam, Tanzania. So, ladies and gentlemen, this is a Paschal Bwire, will be one of the presenters. So his fellow presenter is Johnson Kisanga. He's attained his first degree on science and informatics, and also he has a master's of science in public health. He has 7 years of working experience on supply chain and health information tech solutions in supporting Ministry of Health through immunization and vaccine development program in Tanzania. He is an expert in evaluating and deploying informatics solutions that are country-led, country-focused solutions to ensure local sustainability, which meets the need of Tanzania's e-health strategy. Mr. Johnson has played a role as a system analyst during the development of IVD, Electronic Immunization System, or EIS, that included Vaccine Information Management System, VIMS, Warehouse Management System, WMS, and Fleet Management System, FMS, in Tanzania. Currently, Mr. Johnson Kisanga is working as a program officer at Clinton Health Access Initiative, CHAI, together with Paschal Bwire. So welcome, presenters, and I think you can start presenting, and Harrison Marik will be managing your slides. So you are welcome.
Thank you. Hi, everyone. Paschal speaking. So in this presentation, and we'll be working with Johnson to take you through what we have prepared for you in terms of the supply chain overview of Tanzania. So our presentation outline will include just a bit of introduction of some issues that we'll be presenting. And then we will go direct to the immunization structure, supply chain structure of Tanzania. Then Johnson will take you through the data management systems and inventory control. Then I will come back to finish with the vaccine temperature sensitivity issues and storage conditions, cold chain. Then we'll wind up the presentation with the success and challenges and key takeaways from this presentation. Next. So the immunization program was established in 1975 here in Tanzania. And later, after health reforms, it was changed into Immunization Vaccine Development Program. We abbreviate it as IVD, and it is under Directorate of Preventive Services of Ministry of Health. So the backbone of the program is immunization supply chain, which are the essentials that ensure access of vaccine that prevent diseases and protect the community from the vaccine preventable diseases. So immunization supply chain encompasses the people, products, and the infrastructures, the resources and planning necessary to ensure vaccines stay safe and potent until person who needs them receive them. So in Tanzania, we have 4 tiers that put vaccines from one step to the other. So we have Central Vaccine Store, which is here located in Dar es Salaam, which we use pull system to order vaccines to the UNICEF, and UNICEF and manufacturers deliver them at the port. And then we usually do that on quarterly basis. And we use EPICA currently at MSD. And later, once we move the storage and warehouse management issues into IVDs proper, we are going to use warehouse information management system to manage the stocks. And the fleet management system will be used to manage the vehicles that will be used to transport and distribute vaccines from one level to the other. And then at the regional level, we have 26 stores, which again use pool system to request for the vaccines on quarterly basis. And the national level will be responsible and is responsible for moving vaccines from central vaccine store to the regional vaccine store. And the stock record system that is used is vaccine information management systems. And later, the third tier, which is lowest distribution level, is district vaccine store. We have 185 of them. Again, we are using pool system to do our acquisition on quarterly basis. And the regional vaccine store deliver vaccine to these district vaccine stores. The stock record system which is used is vaccine information management system. And then we have service delivery points. We have a number of them, approximately 7,000 and above. The number keeps increasing every time. So here we use ordering system that is informed push, and BVS usually delivers, and sometimes health facility go to the district vaccine store to collect. And this process is usually done on a monthly basis. And the time that the TIMRI, the Tanzania Immunization Registry, is the one which is used to capture information. It's a mobile-based application that helps the healthcare workers to register their child who is going to be given vaccine, and record vaccinations, and as well managing stock at the facility level. So we have some of the facility are using that web-based tool, that is a mobile application, and some of them that are still using paper, as we are expanding the use of the electronic system at the facility level currently. So I will stop there. Then Johnson will be taking us through the immunization data supply chain management systems.
Hi everyone, this is Johnson Kisanga. Yeah, as my colleague has touched a little bit on the immunization supply chain data management, but my focus will be how the data, as we talk about data, how the information flow is from the central level. As my colleague said, that we have 4 levels of the immunization supply chain. And we have, again, the same levels where the information flow from central level to the facility level, which is the bottom level. And then we have another flow, which is how the information flows from the lower level to the upper level. So starting with how the data flow from the lower level to the upper levels, we have, as my colleague said, we have we have systems which use to manage this data from the lower level to the upper level. From the lower level, we are kind of a mix of data management tools, as we are rolling out the TIMRI, which is Tanzania Immunization Register. This system, it's a registration system which captures the child information record and register child from the lower level, and then the information flows from the TIMRI directly to the VIMS. So VIMS and TIMRI, these are 2 separate systems. The one feed the information to VIMS. So after this information goes into the vaccine information management system, then the data is managed at the district level, and then it goes up to the central levels where we can manage and use the information for making decisions. And in terms of vaccines, from the central level to the lower level, the supplies, as my colleague has said, start from the central level, and then they are distributed using refrigerated trucks from the central level to the regional level, and then the regional level to the district level. They are using trucks, but not refrigerated. So inside the trucks, they put the code boxes, where the code boxes are treated with some cool water packs so that they contain the potent of the vaccines. And then from the district level to the facility level, they also use trucks, and they use the same technology of code boxes, where they store vaccine in the code boxes. So again, there is how these systems help us to distribute vaccines. You can see another picture on your right-hand side. This is how these electronic immunization systems at IVD are used to manage the vaccines. So before the vaccine started to flow from the central level to the lower level, there has to be some kind of a requisition. We call it request. Lower level has to press the order through the system to the upper level, and then the upper level will respond to that order and provide an issue voucher from the system, so that the supplies goes to the lower level, which accompanied with the issue vouchers from the system. But also there is another system which is used to manage these vaccines at both levels, which is remote temperature monitoring devices, because we all know there are vaccines which are heat sensitive, and there are vaccines which are freeze sensitive. So there is a technology which is also web-based, and there is a link inside the VIMS, which if you don't want it to struggle with two separate systems, you can just log into the VIMS and obtain the same link, which you can access your temperature data through the web-based system. And this system is also configured to all refrigerators that are managing these vaccines at all levels. And then you can get the real-time data on your refrigerators, so that you know which refrigerator is maybe misbehaving, or just to know the temperature of the current situation of your refrigerators. So in terms of how the supply data management is concerned, both systems, that's how they operate at 4 supply chain levels of the Tanzania immunization. And then how the inventory control system is working, the vaccines are stored at the central, regional, district, and the way these vaccines, the way they use to request these vaccines, the system itself has set for each levels and for each stores the maximum they can request, the maximum number of vaccine, the maximum number of doses they can request, and its rated supplies. It's automatically, and then the minimum, and the automatically the system has set the lead time, and it can also remind the users on the time they use to make this request. Can you move to the next slide, because I'm talking on the next slide? Yeah, thank you. So at the district, regional, and the national levels, as you can see, they have maximum stock and minimum stock, and this is automatically set by the system. They can request not above their max, and this has been set so that to prevent overstocking or understocking at the particular store. And you can see a snapshot of vaccine information management system on your right-hand side. This is how the stock is controlled. You can see the bar chart, which indicates the level of stock a user can see. The real-time stock, that's the real-time stock, and you can see the real-time stock for the supplies. You know, vaccines are accompanied with the related supplies like syringes and the safety boxes. And you can also get the summary of the supplies that are currently in your store, and then you can be able to know which supplies is overstocking or is having a sufficient amount of stock, or maybe it is understocked. And for this snapshot we have captured the dashboard of the national level. As you can see, we at the national level can be able to see a summary of regional and a summary of district. So if someone logged in as a regional, will be able to see a summary of district and facilities. So it depends, it's user roles based, depends on which level you have logged into the system. Okay.
So thank you, Johnson. Then I will take you through, because we know, as we all know, that temperature is a thing that need to be monitored for vaccines as they are temperature sensitive. And in this slide, I will talk a little bit of the temperature sensitivity of the vaccines. You know, vaccines have been formulated mainly into two major formulations, which may be liquid vaccines or lyophilized vaccines. So the lyophilized vaccines can tolerate freezing. So you can see the greenish bubbles, those we talk about the lyophilized vaccines, which we have in our immunization schedules, BCG and MR, which are the lyophilized vaccines. So the lyophilized vaccine are in a powdered form that can be stored in negative temperatures of negative 15 to negative 25. So the rest, which are liquid formulations, as you can see, they cannot be stored in freezing temperatures because they are freeze sensitive. And they are freeze sensitive because they have been added something called adjuvant, which is called aluminum adjuvant. So with aluminum adjuvant, then the vaccines are freeze sensitive, and we cannot keep them at negative temperatures, because once we keep them there, they will be destroyed and cannot be used anymore. So I have cycled the vaccines down there. For the lyophilized, they have BCG and measles and rubella. It's two for prevention of two diseases, but within a combination of one vaccine. And in liquid formulation, we have a number of them. So as you can see, we have a number of vaccines which are freeze sensitive. So in our program, we are so much concerned of temperature control issues. That's why you can see with the previous presentation, we talked about remote temperature devices that monitor temperature. And this brings me to a topic. Can you go to the next slide? Now I have just taken the vaccines that we are providing in our immunization program, and I've tried to use the same color-coded information that we had in the previous slide. So the purple one, which is BioPV, it's a liquid formulated vaccine. This one, we all, in our previous presentation, we talked about the tiers. So the three tiers on top, that is national level, region, and district, we have to keep this vaccine at negative temperatures of negative 15 to negative 25. And we are keeping them there because they are heat sensitive. And then at the facility level, it's a time that we can afford to keep them at positive 2 to positive 8 degrees centigrade. So that's for BioPV. It's a liquid form, and it has no adjuvant within it. That's why we can keep it at negative temperatures. And then with BCG and MR, these are lyophilized. They are in a powdered form. If we don't have sufficient storage refrigerators, we can afford to keep them at negative temperatures, but usually can be kept at positive 2 to positive 8. Yeah, so that's it. And with the rest of the vaccines, which are liquid formulated, which are in reddish in the this slide, we keep them at negative 2 to negative 8. We cannot afford to freeze them, because once you do that, we permanently destroy them when they cannot be used anymore. So currently we have 8 products which are vaccines. to prevent 13 diseases, which are vaccine-preventable diseases. And as we all know, in few time to come, we'll be introducing coronavirus vaccine. So once we introduce that, then we will be able to include it into our program and see how we store and how we monitor vaccine storage temperatures with it as well. So can you go to the next slide? So this temperature sensitivity issues brings me to this topic of cold chain system. With the cold chain system, this is a system that of transporting, storing vaccines from once it enters the country to the time it reaches the recipient, either a child or adults, because as we know from the inception of the program, we started with the childhood vaccines, and now we are giving even adolescent vaccination and adults vaccinations. So that process requires key elements in the cold chain. Once you transport, you have to have personnel who manages. So with the program that Tanzania is performing, we have dedicated people, personnel who are dealing with immunization program. And we have given them the name that being vaccine and immunization officers. And they are responsible for managing storage and distribution of vaccines from one level to the other. So at each level of the tiers we have talked about, we have these vaccine and immunization officers. So we have national statisticians at national level, and you have vaccinators who are keeping vaccine at the health service delivery levels. So that's one component of our cold chain system. So we need this personnel and the equipment. As we were doing our presentation, we have been mentioning a few of them. So we have working cold rooms and working freezers. These are at national level. We have bulk amount of vaccines to keep. So they are kept at the working cold rooms for those which require positive temperatures from 2 to 8, and working freezer for those which requires negative temperatures. And at the regional level, we have working freezers as well, and working cold rooms, working cold rooms at the regional level. And at the district, we are using refrigerators and freezers to keep vaccines. So with the cold boxes and vaccine carriers and cool water packs, refrigerated trucks, these are used for transportation of vaccines from one level to the other. So that's a second component of cold chain that we have in the country. It's a topic on its own, very broadly. I'm trying to be very brief here. Those are the equipment that we use to store and transport vaccines. And then the third key important element of cold chain is to ensure that vaccines are stored and transported appropriately with procedures. So SOPs, guidelines, and all those things that which needed to have to help these people to perform their functions. And why cold chain system matters to us. We all know that vaccines are biological products. They lose potency time. So they are, once they lose potency, you cannot reverse that process. And it is important for us to keep them at the required temperatures as licensed so that we cannot waste vaccines. Secondly, it will help us to be confident that we are providing to the community potent vaccines, and that brings confidence of the community to the IVD program. And we also make sure that we reduce vaccine wastages, because you can see not only expiries that can destroy vaccines. If we don't keep it well, it will be wastage, as it can freeze, or being exposed to high temperatures, it can compromise potency, and then we have wastage around that areas. And that also brings us to key successes and challenges that we need to see. There are a number of them, but I have just prioritized these few. One is that with the Tanzania Immunization System, supply chain system, we have improved visibility of stock management. So we know when to order, how the stock ledger, we have electronic ledgers for each product we can access at each level. We can better manage cold chain equipment. If the equipment is broken, through our remote temperature monitoring devices that is synchronized with the vaccine information management systems, we can know which one is better functioning or not. And also we can monitor vaccine storage temperatures. We have accelerated alerts that goes from the vaccinators to the district immunization officers to the managers as well. That helps to improve stock adequacy, which are potent. But we have challenges. We know with the internet connectivity issues, with the web-based and mobile applications that we are deploying currently, we have seen some delays in the updation of the information. That one thing can be connectivity, but also we have negligence of our people. So those are the issues that we have to manage and make sure that people grew with these improved technologies in helping their functionings. Then unproductivity of resources flow, resulting in a frequent interruption of vaccine distribution operations. This happens mostly in subnational levels, where we know sometimes unavailability of vehicles or limited budgets makes them difficult to deliver vaccines to the facilities on time. So to finish this, next slide, Alison, to finish this, we need to get some key takeaways. And to drive this, we asked ourselves three big questions. How do we facilitate vaccine delivery? That will be first question we need to ask ourselves as we are taking away some key issues from these presentations. How do we prevent missed opportunities? And third question that we need to ask ourselves is how do we develop the capacity of our staff to do their job well so that we have vaccine delivered on time. So this thing, we have to improve visibility of the data we manage from immunization supply chain. So once you have issues that you have identified, because you have more visibility, you know how temperature is behaving, you know when you have lost stock, when you have broken fridge, you know when you have understocked facilities or district vaccines or regional vaccines. So once you identify those bottlenecks that prevent someone to deliver vaccine perfectly, then we do timely identification of those bottlenecks and prompt responses to make sure that we alleviate those issues, bottlenecks. And then we have to design and implement interventions that address bottlenecks. To our immunization supply chain, we brought in a lot of technologies like remote temperature immunity devices. We have information management systems. We have TeamView. It's all to help our staff to identify issues on time and respond them on time. And then we keep monitoring and evaluating our performance along the way to have continuous improvement for immunization supply chain. And then to the audience that you joined us in this call, what takeaway could you take from this presentation that can be useful to your programs that you work on or you are managing? Thank you very much. This is what we have. So questions, I think Fahan was managing that, and we can respond to them.
Thank you. Thank you so much, Pascal and Johnson, for the nice presentation. You have touched every angle of the supply chain that we can speak with this one of the vertical programs that it's unique. As you know, you keep on mentioning it's unique, and it's very sensitive because the products that we are dealing with not only biological products, but also they are very, very temperature sensitive. If you mess, it means you mess with a lot of millions of money that the country and donors they're investing to save lives. And you mentioned almost in country so far we have 8 vaccines that they're protecting 13 diseases. But also you and Johnson have mentioned about how the systems are there in Tanzania to improve data quality and data availability for making the better quantifications and so forth. So thank you so much again for this nice presentation and joining with us. I know we gave you a very few minutes because we wanted people to provide much more comments and questions so that we can respond as one of the panelists here. So let me invite my colleague Farhan, who is managing Q&A or question and answer session, so that he can read and Paschal and Johnson, they will respond. So far, I think we are still waiting for IVD program manager. If you join also, will be one of the panelists who can respond on those questions. I just want the participants to understand, if you have any question or a comment, please put in the Q&A session at the bottom of your screen. Or even also you can put in the chats, Farhan will manage it. So Farhan, please.
Okay, thank you for that presentation, our facilitators for today. And thank you to all the people who've sent their questions so far. If you have any questions, please, the room is still open. We've kept quite some time for the Q&A session, so please feel free to share your questions. I do see 2 points are with regards to sharing of the presentation. I believe, Richard, that is something we can do after the call today. So the presentation will be shared to all the people who registered via the email addresses that you all registered. So I'll start off with that, just get that sorted. Facilitators, I see there's a few questions. So what I'll do is I'll maybe read 2 of them at a time, and then you can answer, and then we'll move on to the others. So the first question is, does IVD oversee all human vaccines in Tanzania? Since I noticed that some vaccines such as hepatitis B do not flow through the IVD channel. So this question is asking about, whether it oversees all human vaccines. And the second question is about the capabilities of TIMR. So does it offer real-time data visibility at the health facilities? What capabilities does it have in terms of reporting? So if you guys can start with those 2 questions.
Yeah, thank you. Thank you very much, Farhan. So with the first question, does IVD oversee all human vaccines in TZ? No, not all. Some are with the epidemiology section of the Ministry of Health, like yellow fever. So you see hepatitis B in the presentation because at one point of time when they were brought into the country, IVD program managed them for the first time. So we included it there. In our program with the Penta vaccine to the kids, we have it in that combo vaccine there. So we have it in a combination and it is given to the children only. Then with the second of team capabilities, Johnson will take that question.
Yeah, I'll take this one. So the capability of TIMRI to provide real-time data and visibility at the lower levels where it is being used, it can provide real-time visibility and real-time data, but also it is connected to the upper level system, which is at the district level, which is VIMS. So at every end of the month, the information that are entered at the facility levels are synchronized in VIMS, and you can have visibility upper levels up to the central level. So yes, they can visualize the information at their levels, and they can have they can make decisions on the information that they have captured. They have the dashboard where they can visualize and can even generate reports, and they can do the stock management issue and stuff like that.
Okay, thank you for that. I hope the answers were clear. If not, please feel free to add. So both these questions were asked by Vicent Manilizu, and next question is from him as well, which is he is concerned that lead times are the same as minimum stocks at all the levels. Does this mean supplies are always delivered in time less than the stipulated lead times to avoid stockouts? I think you guys can answer this. The next one is slightly different. So the question is around lead times and minimum stock levels.
Yeah, so the maximum stock for is illustrated on the presentations. For they differ at the central level, but at the regional and the district levels, the maximum stock is 3 months stock, but they can have at least a minimum, but not less than 1 month stock. And the lead time, which is, they can request, it is automatically included in the estimation of the maximum stock. So for a region and district, we are using at least a month for 4 weeks for calculating and estimating their needs. So it's there is a calculation inside it. I don't want to go into much details of that, but at least 1 month is sufficient, because when you press waiting until you get, that's why we have put, and we have another level we have not included it here, which is reorder levels, where it is when they are supposed to make a request. So that is at least 2 months. So you press the order when you have a stock of 2 months, and then when you wait for to be stocked, and then you are at least consuming the ones that you have up to the minimum, which is the month. Then we are assuming that you will be already supplied with another stock back to the maximum stock. But we know that that is theoretical part of it. Sometimes practically it can be possible, it can work, or it cannot work. But the system is set to remind someone at the levels which is a very safe level, so that you don't request while you are at the minimum level.
Okay, thank you. Moving on to the next question. These 2 questions rather, these are from Nuran Idris, and her 2 questions are: number 1, given the upcoming COVID-19 vaccines and also given the rampant falsification challenges, is there something you are doing to handle these medicines in the WIMS in face of global trends? And number 2, broadly, what mechanisms are in place to deal with the challenge of counterfeit vaccines, which is a global issue?
Yeah, so with the falsification challenges that are happening with the COVID, we know now countries preparing some of the introduction issues. So there are special department that is dealing with the thing. And once we are certain with which product will be introduced with the country, then we can update the system to accommodate. We know when we were doing the design of vaccine information management system, we took consideration of the future introductions. So they will be updated and taken care of the any new vaccine that is coming in. For example, by the time we had this information system in place, we have already introduced a number of vaccines within it, and we are managing them, like IPV, HPV, and hepatitis B is by the time the program was handling it. So that's it with the, yeah. So with the counterfeit medicine, I know the country has stringent processes of looking at the quality of and safety of vaccines. So we have TMDA people that are doing that work with the system we have. They are the one who are responsible for managing that. We as a program, we are beneficiaries. So what we do is to make sure that we make orders to the reliable resources, and within us, all the program vaccines are procured through UNICEF, not from any other manufacturers who are out there. So we have our sources which are reliable from UNICEF Supply Division, with collaboration with the UNICEF in country here. So we are certain that what the product we are receiving, they are of quality and safe and potent for the citizen of Tanzania to use them. With the global standards, yes, we have to manage that, because with the program itself, it is mandated to report to UNICEF and WHO on a monthly basis. So if you have information that at the end of the month you need to reprocess again, then it's difficult. So we made our reports to respond to that need of global reports. So it meets the global standards, and particularly we have sought out with UNICEF and WHO, because those are the one which are demanding to the program to report on a monthly basis. But any other thing can be customized from the reports that we have.
Okay, thank you for that. I see questions are coming in and we don't have that much time, so just trying to get through all of them. So I guess the next few questions are, talking about facility level. So there's a question on, is visibility seen up to the last mile point? So at the health facility level, how are these vaccines administered? And also there's a question I see below, which is facility related, so I'll ask it now, is the quality of data. There have been issues with quality of logistics data reported by health facilities. This has not been heard as a challenge in the program. What is the experience like? So 3 questions asked by Peace, asked by Neema and Bosco regarding health facilities: visibility, administration, and data quality.
Okay, so yeah, so I think I've talked about the visibility across the supply chains level of Tanzania. So we are able to see up to the facility level data, because there is a web-based system at the facility level. I know there are challenges associated with that, but we are here to work and resolve that challenges, and that is the goal, to have the visibility up to that level. And at the how vaccines are administered, let me handle this to Paschal.
So I can just put them like this. We have vaccines that are administered orally. So the vaccines that are administered orally, we have 2. We have those we are administered by injection intramuscularly, or subcutaneously. So just as a topic on its own, it could have not have enough time to present that. So we have major 3 routes of administration. So orally, intramuscularly, subcutaneously, administration of these vaccines. I hope you mean that by administration, and I can respond towards that.
Okay, and what about the question regarding data quality at the facility level?
Yeah, quality again. It's true. So that's why we are trying as much as possible to help. With the 3 takeaways, how can we help our staff to even work better? So what we have done is to make sure that we reduce a lot of paperwork from them. So now we are using mobile app to make sure that we capture information and keeping restrictions to some of the issues. Still, we have those challenges, we know. But what we are trying to do is to make sure that as much as possible, we reduce the workload to these people at the facility, because they have to vaccinate, they have to transfer vaccines, they have to manage the cloud. So it's by putting some of the innovation and incentives to them, like what you have mentioning, like putting mobile app. They have visibility of the information from the upper level, alert systems. So we know data quality is an issue, and it's an issue that we are keeping looking at it and improving every time and then. So it's not 100% perfect, but from where we are and where we are, I think we are in good direction.
Yeah, maybe to add on that, we are trying to put as much controls as we can in the system, because there are sometimes the date data can be also being caused by the too much entries, but also when the system is very open, like you can just put the letter, someone can put the numbers, or vice versa. But so also putting controls, sometimes, like I can give you example of, you may have run a report and discover that the number of children vaccinated is higher than the number of doses used. So, if you run a report like that, you automatically know that there is a quality data issues here. But we are trying to minimize those risks, but we know that it takes time, and sometimes you need to also educate people at the lower levels, provide some kind of mentorship, refresher trainings, and conduct verification, so that we end up with data which is clean, so that we make the right decisions.
Okay, thank you so much, panelists. I see there are a few questions here that are talking about, harmonizing VIMs with ELMIS. And also another question, since ELMIS has capabilities that can offer warehouse management and reporting, do you think using ELMIS to the level of facility would provide more efficiency? So questions around harmonizing with ELMIS, and whether, using ELMIS to the level of facility and avoiding the mobile app would be more efficient.
So let me start with the harmonizing. So we don't have much time to talk about where we came up from having VIMs, what was the story, what was the history. But VIMs, I can say this way, VIMs is like a baby of ELMIS. It has come from the other side of ELMIS. So when we are saying harmonizing, it's like one is a parent and the other one is a kid. So you don't harmonize a kid and a parent. They are already harmonized, and that's why someone come out on the side of the other one. So I think I can put it that way. And capabilities, I think even team is capable of doing what is intended to do. There are some decisions and issue like that which is beyond this call and beyond our decisions. So I think I would not respond to why should we not use this and this? Because even while we are here using it, there was so much effort until we are now. So
yeah, so the issue is with the immunization, it's more with the supply chain, it's beyond stock management. So the issue of capturing information of routine data, routine vaccination that are happening. So the tool that would have more capabilities beyond stock management was found to be more preferably utilized with the program. So with the systems we have, they have extra functionalities beyond stock management that you can see. We talk about routine vaccination data, we talk about cold chain data, we talk about temperature monitoring issues that also are also monitored. So those all information are captured with the systems we have. So we are holistic approaching immunization supply data in those angles. So that's it.
Okay, thank you so much. So I think we probably have time just for one quick question maybe, and I'll ask it because it has to do with quantification, and I feel that's a relevant topic, and then Richard will come and close. And so the question is with regards to, you know, the readiness of the program to capacitate the facilities to quantify for their demands rather than top down as done recently. I think this also comes from the fact that in other programs we are seeing bottom up quantification. So maybe it would be nice to have insights on this question.
So at the facility level, I think what we give them is the target. So basing on their targets, that's what we said. Maybe next time we can prepare a session exactly to see how we come up with the needs. So with the facility level, they are given the target. With the target, they generate their requirements that they quantify their need. So they, for each product, they will have the requirements for a year, for a month. And then, as we know, we are giving them vaccines for 1 month and a half and 2 weeks. So every time we replenish to the maximum stock that they have to keep. So in actual fact, they know their needs. They calculate their needs from where they are, and then we replenish them accordingly. So with the national level again, our forecast, our quantifications targeted based, is not consumption method. It's a target based, and then we have the calculations of what maximum stock we need to use and what to keep, what the order levels and everything. So there are a little bit some calculations that we need to talk about, and each level is calculated. So if we have the full pipeline of 6 months, 3 months, 3 months, and 1 month and a half, the program will have product for 1 year and 2 months. So if we have full pipeline, then we have no issues with the stock outs so far.
Okay, thank you so much. So for those questions that we haven't been able to get to, we will ensure that we send answers through the listserv that we have, and we'll probably share that on the WhatsApp group as well. Thank you so much, everyone, for your questions, and the panelists for their answers. Richard, over to you.
Thank you so much, Farhan, for managing the Q&A, and thank you so much for panelists for a good response that you provided. I know the time is not in our side, but as Farhan said, we'll make sure we contact you to provide the response. And I really appreciate for all those participants who have taken their time to join with us. And as you know, these vertical programs, especially the uniqueness of the immunization supply chain, if you are not in your workstation engaged with this, you may miss a lot of information. I think this is the why we decided with the country that is going on, like we the priority of getting COVID-19 vaccine in our country. So it will be nice also first to understand the supply chain. So I know we have only 1 minute, and I think I should say thank you so much for IAPHL Executive Committee, represented by Rachel Simon, who's she's in the call, but also thank you so much for everyone who made this is making real. And just to let you know, we are going to have another session like this, but not in immunization, with another topic on 28th of August. I will send a notification again. And as IAPHL Tanzania Chapter, we are intending to improve our supply chain, not only just by increasing the awareness, but also trying to be an evidence-based presentations and experience that we'll be working. And we'll keep on inviting the government stakeholders to be with us so that we can discuss at a wider angle. So thank you so much, everyone. And we'll be online just to respond to the questions, but I should say thank you to everyone. And this is the end of this call or webinar today. Thank you, everyone. Bye-bye.